We are continuing with the endocrine system and going to discuss Graves' disease and multinodular goiter. Graves' disease is the most common cause of endogenous hypothyroidism and also called diffuse toxic goiter. Presents as a clinical triad of hyperthyroidism due to hyperfunctional diffuse thyroid enlargement, exophthalmos due to infiltrative ophthalmopathy, and pretibial myxedema due to localized infiltrative dermopathy. It's an autoimmune disease, and autoantibodies are directed to give thyroid stimulating hormone receptors, thereby stimulating them and secrete thyroid hormones T3 and T4. Graves' disease is the most common cause of hypothyroidism in the United States, and auto is more common in female. Women are affected 7 times more frequently than men, and the peak incidence is between 20 and 40 years of disease, and there is 30 to 40% rate among identical twins. It's basically an autoimmune disease and is characterized by hyperthyroidism due to circulating autoantibodies against thyrotropin TSH receptor that activate the receptor, lead to increased thyroid hormone synthesis and secretion, and as a result growth of the thyroid gland. Presence of thyrotropin receptor antibodies in the serum and ophthalmopathy on clinical examination distinguishes Graves' disease from other causes of hyperthyroidism. And as we had discussed, it most commonly affects middle-aged women with female to male ratio of 4:1. And it has association with HLA class 2 molecule HLA-DR. Patients also present with ophthalmopathy, that is due to thyroid stimulating antibodies that activate T cell cytokines such as tumor necrosis factor alpha interferon gamma and stimulate adipocytes to proliferate and orbital fibroblasts to secrete glycosaminoglycans like chondroitin sulfate and hyaluronic acid, which increases the osmotic pressure and retention of water and causes inflammatory edema and swelling of extraocular muscle. Laboratory findings include increased T3 and T4 levels and increased uptake of radioactive iodine and decreased thyroid stimulating hormone and positive thyroid receptor antibodies in the serum. Grossly, the thyroid is diffuse and symmetrically enlarged with beefy red curved surface, and it weighs 50 to 150 grams. This is the gross picture of a cut surface of a thyroid, which shows this lobulated and beefy red cut surface with intact capsule. Microscopically, there are hyperplastic thyroid follicles with papillary infoldings. There is basically diffuse hyperplasia and hypertrophy of the thyroid follicular cells. And hyperplasia is increase in number of cells and hypertrophy is increase in size of the gland. And these with retention of lobular architecture, and there is prominent vascular congestion. Tall follicular cells with papillae can be seen, but they lack the fibrovascular cores and their nuclei are round and basally located. And they do not overlap, and there are no nuclear features of papillary carcinoma like orphan anion nuclei or nuclear grooves. Colloid is typically decreased and presents as shows, and when present, colloid shows peripheral scalloping. Colloid may increase after treatment. This is the histologic picture of a thyroid you are familiar with. It comprises of variable size follicles filled with colloid and lined by follicular cells with which line the follicles, and there is, you can see, no overriding of the nuclei, and they contain round nucleus and fine granulars with fine granular chromatin and eosinophilic cytoplasm. In between these follicular cells, you can see parafollicular cells which secrete calcitonin. This is the histologic picture of a patient with Graves' disease, in which their thyroid follicles are hyperplastic due to increase in size of the follicles with abundant colloid formation, and they presents with papillary enfoldings. So you can see a papillary with enfolding inside due to compression of the follicle from adjacent thyroid follicles, and and with scalloping of the colloid material as round vesicles seen on the surface of the papillae. And if you've noticed these thyroid follicles, they are round, basally located with no prominent nucleoli, and there is hardly overriding. They are standing in one row. There is no overriding of the nuclei. Features of papillary carcinoma are also not seen. This is the gross picture. This is the gross picture of dermopathy, also called pretibial myxedema, in which there is accumulation of high glycosaminoglycans and infiltration of lymphocytes with accompanied by edema, uh, and it is an autoimmune condition. Goiters also is thyroid enlargement and is the most common manifestation of thyroid disease due to impaired synthesis of thyroid hormone with resultant TSH production, which results in follicular hyperplasia to restore the euthyroid state. If the compensatory hyperplasia cannot overcome the impaired hormone synthesis, then goitrous hypothyroidism results. It's also called thyromegaly, and it could be diffuse or nodular. The cause of goiters is like its iodine deficiency, because deficiency of iodine results in impairment of synthesis of thyroid hormones. When T3 and T4 are not synthesized, that results in increase in TSH levels, and these TSH levels will further stimulate the thyroid follicle formation and increase in number of thyroid follicles, and the patient presents with the goiter. That if it's like the certain, there are goitrogen substances that leads to formation of goiter, like cabbage, sprouts, cauliflower, turnips, cassava, and goiters are associated with hypothyroidism eventually. These are the pictures, some of the pictures of the goitrogen substances. With iodine supplementation, the frequency and severity of endemic goiters has decreased in areas where iodine was endemic, like Himalayas and Alps. But there are certain substances in diet with high goitrogenic substances, like cruciferous vegetables like cassava, cabbage, and turnip. They precipitate simple goiters. Sporadic goiters occurs less frequently and they are more common in females, and cause included goitrogen ingestion or hereditary defects in thyroid hormone synthesis. This is a lady presenting with a goiter that is enlarged and huge and is multinodular. Recurrent episodes of stimulation and involution of diffuse goiters results in irregularity and enlarged multinuclear goiters, and they produce extreme thyroid enlargement. Multinodular goiters occurs in variation in follicular response to hormone stimulation. It could be due to echoic mutations in TSH signaling pathway, They results in formation of nodules with autonomous growth. Grossly simple goiters are firm with amber cut surface, and multinodular goiters are asymmetric, large up to 2 kg. Cystic and hemorrhage change can take place with brown gelatinous colloid nodules with focal calcifications. Capsule is usually intact and surface is bumpy. This is the gross picture of a multinodular goiter in which you can see multiple nodules of variable sizes filled with colloid, and a shiny capsule can be seen on the external surface. Microscopically, there are variable sized dilated follicles with flattened hyperplastic epithelium due to increased amount of colloid. Nodules may be present but without thick capsule. Secondary changes can be seen in the multinodular goiters like hemorrhage or rupture of follicles with a resultant granulomatous response, fibrosis and calcifications, and even osseous metaplasias can be seen. This is the microscopic picture of a multinodular goiter in which you can see these large follicles filled with colloid and with lined by flattened hyperplastic epithelium where to one side, and these you can appreciate the large follicles with abundant colloid material. In between these follicular cells you can see hemorrhage or really calcification can be seen, or due to these follicles, if it's multinodular goiter, are dissected out by fibers.